now from one of our specialty health networks, Elizabeth Koff, who's the Chief Executive of the Sydney Children's Hospital Network.
Thank you very much, Rowan. Good morning, everyone. Matt, that's a hard act to follow. Thank you for the opportunity to present the journey we've been on in Sydney Children's Hospitals Network, which is satisfying to see from all the other presentations and discussions from earlier this morning. We're on the same path. One important piece of information that I didn't recognise was the period of the presentation was reduced from what I originally prepared, so I'll fast track as appropriate. Hammurabi, sixth king of Babylon, 1700 BC, who was famous for Hammurabi's Code. For those who may be aware or unaware, contains such gems as an eye for an eye and a tooth for a tooth. Why does he warrant mention? Payment for activity has been around for many, many years. And the sophistication of uplifts or uploads or downloads, and even punitive action for adverse outcomes have been on the agenda. The challenge for us in the health system then, in this day and age, how do we position activity-based funding in all the, responsibilities we have in delivering services at the local activity? It's a really complex soup of initiatives that we're grappling with. Activity-based funding sits somewhere in the middle. I like to view it as a cornerstone and has been described regularly this morning as a tool that we need to help us navigate the multitude of reforms, service models, changes of care that we need to undertake. Activity-based funding in itself is not the means to the end. At the district level or network level as described and has been consistently been mentioned, it's a complex intervention. It requires governance adaptations, organisational change, education. Can't be underestimated the explicit linkages between ABF and quality and IT and human resource investment. It is complex and it does operate across many facets of the organisation. The three T's that I chose just quickly to briefly mention, the macro, meso and micro, but I think we were well informed of the macro level intervention in this morning's presentations when we looked at it in terms of the national and the state agenda, but I've lowered a little bit to the network, facility and patient level. And I think it looks subtly different at every level, and the understanding, the knowledge that people need to have varies at each of those levels. At the network level first, I think it's important to recognise that, as I stated, activity-based funding is not a strategy in itself. And in another unreadable slide probably, it just gives you a flavour of the network strategy map, which is a comprehensive strategy for the network focusing on clinical care, research, education and advocacy. However, activity-based funding is not mentioned once in our strategy map. It is, however, an integral part of multiple components of the initiatives that we do identify in our strategy map. We want to be a high-value organisation that meets international benchmarks. We can only do that by strongly bringing forward the agenda of activity-based funding and quality outcomes. Innovation in patient care will only be delivered with the assistance of ABF, and adaptation or adoption of international best practice comes with that also. So activity-based funding, critical to what we're doing, but it is not the strategy in itself. In preparing us to go forward in the ABF environment, there have been some useful supports provided by the Ministry with the KPMG review planning for ABF. I think that gave the board a degree of comfort and the executive a degree of comfort that we had started on what was a long journey and required significant investment locally in how we rolled out ABF. The IT investment that we need to be able to support ABF was critical, and CHIMP, our Children's Hospital Information Portal, which is constant work under progress, is aiming to provide the information that we need in a timely and accessible format to assist in critical decision making. On discussion of the implementation of ABF at the network level, you can't underestimate the risks. The immaturity of our systems and the timeliness and accuracy of the information that we have really make it somewhat perilous in instances to make significant shifts in budgets on the basis of this information. And major service modifications or reconfigurations need to be considered in the context of full information that is accurate. And that's where the power of ABF will sit. But I would hasten slowly in undertaking some of these until we're 100%, well, whether we're ever 100% confident, I don't know. But the validity, integrity of the data, I think, is critical because it could be very disruptive organisationally. And once again, it's not just about the cost. The quality needs to be there. At the facility level, once again, the initiatives that are required relate to education, and the ABF task force that's done an excellent job coming out to the LHDs and the networks has been critical in assisting us in developing those education needs. I struggled a little bit to find a picture because hopefully most medical records departments don't quite look like that now where they're going for the EMR, but graphically it was hard to depict. But the strong message is, in terms of organisational changes, relationships are changing and clinicians and coders are becoming newfound friends. I visited our medical records department the other day and they're on first name terms now with most of the doctors, which they're absolutely delighted about after being stuck away in the bowels of the organisation. In an attempt to continue to reiterate the quality and ABF nexus, we're doing some work with coders on the Between the Flags initiative and coding. Also, we've got to make it easier and simplify how we do. So we're going from paper-based coding queries to electronic. The relationship with finance changes dramatically under ABF, and we've gone on a journey of changing the way budgets are allocated to departments and subspecialties. Even some interesting things that we've found to date with our heightened attention to ABF and quality of outcomes was in cochlear implants, whereas the DRG coding outlines the cost for a single one. Best practice now is for bilateral, and the costs actually don't reflect adequately the cost of bilateral cochlear implants. So understanding that helps us then advocate for what should be done, but we will continue to do bilateral even if they are a loss leader, so to speak. Clinical care in oncology, clinicians have come together across the site and identified significant variations in practice and in a number of DRGs, and we've undertaken significant work and demonstrated improvements and reduced the average length of stay in oncology for a number of care types. Important to that also is how we assist and provide the tools in coding to facilitate that, and some examples of coding sheets are listed there. Not as sophisticated as the app at Sydney Teresa, but definitely we've got it electronically. I would emphasise we need to ensure that we do not compromise the quality of care with understanding some of these cost perversions. we must not be reluctant to move to new models of care based on where we see better return on investment. The model and quality of care should always take precedent. And what does matter the most is that the care is safe, high quality, efficient and appropriate. Sorry I went so fast at the end there. Thank you.